Chair of the Finance Committee, and welcome everyone and call our meeting to order. First thing to run over real quick is a conflict of interest. There's an opportunity for each member to disclose potential conflicts of interest and their beliefs that they could be unbiased and able to participate, or that they elect to recuse themselves from this matter. I did want to just mention one thing in the Finance Committee, as I think this is important, and we talked about this actually yesterday, and recommended that we work on an updated version of conflict of interest statement for all members of the board, for procurement and the executive leadership team. So we're signing that on an annual basis. I think everybody was pleased to make sure that happened, as I'm sure many of us serve on lots of other boards and are used to doing that regularly, and will be more in line with audit procedures going forward. So I think that'll be a good thing to have. Next matter on the agenda is the minutes. If everybody has had an opportunity to review the minutes, do I hear a motion to approve the minutes from the last Finance Committee meeting on January the 25th?
Move approval.
Is there a second? Is there any discussion? Hearing none. All in favor?
Aye.
Aye. Motion passes. Okay. Next item is the fiscal year audit update. Naramore.
Just going to be a brief verbal. Our fiscal year 23 audit is complete. We actually have the final draft. Our partner from Crossland was unable to attend today. And historically, just for the newer board members, our board has always liked to have the auditors actually present in the board meeting so that they can respond to questions, discuss the audit, and talk about the upcoming year. So Mr. Hunt is in Indianapolis, I believe, today with another client. He could not be here, so we're going to reschedule them to come and visit with Finance Committee and board at the next meeting. Potentially a special meeting if timing is required, but we do have the final draft of the audit and so forth, and we can send it out. But typically we have not done that because it's a public document. We would post it 7 days before that meeting occurs. Okay.
Understood. Next item on the agenda is fiscal year 25 budget review.
Awesome. Thank you. Just as an update, I don't know for new members or old members, older members, last year we presented our budget to the Metro Department, to the mayor's office in early March, just like we're going to do this March. But the Mr. Dietz, legal from Metro, opined to me and to Dr. Webb that in fact Metro agencies should have their initial budgets approved by this board before it gets to Metro. So in meeting that requirement, that's why we are bringing this initial budget proposal to this board, to the Finance Committee and the board for initial approval, with the understanding that it's highly likely that there will be changes to the budget, whether that's from the mayor's office suggesting a different number than what we're requesting. We're going to update 1 or 2 more months of financials, so our projections may be a little bit different, but we're trying to bring the best budget forward today that we could, and so that's what we have in your packets today. And so first, I just wanted to walk through, I wrote them out for you guys, but basics for sort of the assumptions underlying the budget that we're bringing forward. So we have 6 months out of 12 actual, and then we're projecting the next 6 months against what our budgeted is for 2025. So just a little bit of heads up. The new locations like the Bordeaux Clinic that just opened and the imaging center there that's opening sometime probably in April, and then the Metro Center Clinic that just opened February 4th or 5th of this, the month we're in right now. Those are budgeted as net new in the 25 budget, so we didn't ignore them. They're in there, and they're projected based on either their history or their projections for the full year 2025, because they should both be fully operational July 1 through June 30, 25. And then physicians who joined the hospital in the last 12 months, we've taken whatever their most recent 3 or 6 month trend is and bumped it up basically 10% to project for what we believe their volumes will be in the next budget year. Wages are budgeted with a 5% increase. So if you have been here at least a year, your annual wage would be expected to be up 5%, and that's what we're using in the budget. Supply costs for general supplies, 4%. We get that from our group purchasing organization, their projections. And pharmacy is projected at about a 6% increase. The current budget that we're bringing forward, we're not anticipating or budgeting for any degradation of our billing process related to the Cerner Oracle installation that will happen sometime in the summer, early fall. It probably will have an impact on cash flow, but it shouldn't have an impact on actual revenues for the hospital. So we did not make a correction there. We also assume that all of the federal and state dollars that we've received in the year we're in will continue at those same levels for 2024 or 2025 budget year. There are 2 exceptions. You probably remember we got a $3.06 million payment, one time only, and it just ran out. In December, we had accrued it for the 6 months of this year, first 6 months of this fiscal year. That is non-recurring, so that is not in the budget going forward. It was paid out of ARP funds from the state. And then also, we received a $450,000 payment from United around the TennCare program that, again, was one-time only money, and it was supplied through ARP funds through the state. So those are the 2 that we did not projecting to go forward. Also, in the fiscal year that we just ended and was audited, we did receive $1.1 million of state graduate medical education money. That money used to go directly to the medical schools, which was not standard. And in other states, those dollars have gone to the hospital, not to the schools. So the state of Tennessee made that change in 2023 under pressure from CMS. And so they made that change. And so for the first time, we received the state GME money instead of Meharry receiving that money. However, in 2024, this year that we're in, we have not been able to get any of those dollars because we've not been able to get the resident work schedules from Meharry in order to draw those funds down this year. So until we get those, we cannot participate in the state GME program. And so right now I'm not budgeting that we're going to get that 1.1 million. We haven't gotten it in the year that we're in right now. So the other is, just as a side note, in 2018 fiscal year, we received $52.0 million from Metro. And now in the budget 2025, it's a $63 million request. And there's a slide that we use in our presentations that shows if you take the 52 and basically it's a 2.9% annual increase since 2018. So even though the 63 feels high, 3% annual increase over those 7 years is really probably better than most hospitals have done from that standpoint. So those are just some high-level operating budget guidance for you guys to consider. Then after that, we have some assumptions. The assumption is it will have a 3% growth overall. Emergency department visits, admissions, hospital admissions, and our clinic visits, with the exception of the new clinics or the physicians that joined us in the last year. We made separate arrangements for those. The outpatient services would also grow 3%, but the imaging center is obviously net new volume. And then we have those 2 new clinics at Bordeaux and then the one at Metro Center. Those are individually budgeted. separate. And then we had a few doctors that we did hire or came to us in 2023. Dr. Sands is primary care, Dr. Tunya is internal medicine, Dr. Maliakal is a GI physician. And so they're for the full year 2024 and budget 25. Dr. Kelly that joined in cardiology, Dr. Nguyen just joined in OB-GYN, and then Drs. Lightford and Crayon just joined the hospital in February. We do expect we increase our charges, not necessarily what we get paid, but we will increase our charges by 5% on July 1st, 2024. That excludes professional fees and chargeable supplies because those are charged based on acquisition costs or based on market rates for professional fees. Like I said earlier, wages are budgeted to increase 5% for those that are eligible. And the other revenue, we did not bring forward the 1.1 in GME, and then we backed out the 3.5 of one-time monies that we secured this year from ARP funds. So those are the assumptions. And then if you look, there's a spreadsheet, hopefully relatively easy to look at. As I said, on the left side, the column is our actual, 6 months actual, and then projected for the final 6 months of this fiscal year ending June 30th versus our budget for 2025 for the full year there. And you can see just sort of the rough numbers. Our revenues, gross revenues go from 307 million to 331 million. Our actual collected patient revenues go from just shy of 54 million this year to 61 million next year. And then you can see in the other revenue lines, in the additional state funding, you can see where basically $3.2 million is backed off from that line. And then the request of the city's supplement support for the mission is 63.8 million. And you can see expenses as they're projected. Salary expenses are up about almost 13%. A lot of that is related to new physicians that have joined, but impacting a full year of salary, and then the clinic staff that support those physicians. We're projecting contract labor to drop about $1 million next year. We've been working on it for a while, and just as a comparison, 3 years ago, before COVID, our contract labor was less than $3 million a year. And it has gone as high as this year's 13. Last year it was about 11. And we're projecting a slight decrease for next year. Most of our benefits and FICA and so forth are tied to our salary expense. And then you can see supply expenses. Those are adjusted for volume and then for the 4 or 6% increase in pricing. And then most of our other expenses are pretty close to current and projecting small increases there. For the year that we're in currently, we have a small positive operating margin. And for next year, in this budget, we have basically a $1.5 million positive operating margin. And then the last thing I'll just say, depreciation and amortization, that is an expense that is going up because we've acquired a good bit of equipment in the last year, particularly the imaging center, and those lease costs for that equipment runs through that depreciation line. So that's why that jumped up this year. So we have a small loss in the year that we're in and a slightly larger loss next year, although it's non-cash. It is depreciation and amortization driving that number. So this is the initial budget with a 6-month and projected, and then for next year projected. So this is a July 1, 24 to June 30, 25 budget that we're planning, Dr. Webb and I will share with Metro on Tuesday. And I won't tell anyone that it's Dr. Webb's birthday, so that's how he gets to celebrate Tuesday.
Bruce, on the GME
Yes.
money, before it went to Meharry, and then did it come to the hospital? Or did they keep it?
Meharry kept it. I mean, Vanderbilt too. It wasn't just Meharry. There were a lot there, and UT, same thing. that money had been going. I mean, you worked at a hospital.
Yes, but
And in most states, in every state I've been in, GME from the state goes to the hospitals, because GME and the way it really functions is it's paying back hospitals for the inexact, less efficient care provided by students who are being trained to be physicians. So that's the whole concept of medical education. They'll pay for some of your direct costs, but they also pay hospitals for the inefficiency of having a lot of residents work in your facility. That's kind of the basic concept. But in this state, I think we were the only one left. You had UT, Vanderbilt, Meharry Medical College. There may have been some others where those dollars were going directly to the medical schools rather than to the hospitals. So the state was under pressure to change and follow in step with the other 48 or 49 states to pay those monies to the hospitals rather than to the medical school. We didn't have anything to do with it. We did not drive it. We did get the money in the first year, which was 23, because they didn't require us to send the resident schedules in that initial year.
Okay, but the federal GME money comes to the hospital, correct?
There is some GME. It's roughly $1 million for that. The federal money does come to the hospital, yes.
To receive that, don't you have to have the residents'
Yes.
schedules?
Yes.
So
But,
we're not.
but remember,
we're not
I'm
getting
going.
that either.
No, we're getting that because we file that in our cost report, but it's about 6 months after the close of the fiscal year. The state is requiring we give them real-time schedules. So, and I'm just telling you, Meharry is giving us schedules for the past year, and that's what we use to file the cost report for the year that just ended June 30, 23. The challenge is they've never had to give us real-time work schedules for their residents a quarter at a time. So they're struggling with it. I can't get those schedules right now from Meharry for all their programs. So until I have them all, I can't submit. I don't know whether we're going to be able to get those 2 quarters that we missed or whether those are gone. But we are working with Meharry to try to get all those. There are a host of issues. Social Security numbers, very detailed resident information is required. And it does change. You know how programs are. They change in that. So we need to see them pretty soon after June or the quarter that ends in September. We have to have that in order to submit those to the state to get the GME dollars. So it's new to them to have to do it real time.
I mean, didn't they have to do it real time when they were receiving the money?
I don't know exactly how it operated and Meharry has a lot more students working than just at Nashville General, right?
But this is not about students.
This is about residents. I'm sorry, about residents, yes. They have residents that work in other campuses than just Nashville General. So those places probably are eligible for this GME money, and like me, they're probably not able to get it currently because I don't think Meharry's singling us out to not get those schedules, but they're struggling to get it to us. So I hope we get it. I know I have to have, when I file the cost report for the year we're in, we've always been able to get it. Sometimes it's tougher than others. But we've gotten it. We filed our 23 cost report at the end of November, and we had those schedules. It's the fact that I need the schedules for these 2 quarters that just ended, and we don't have them. We still don't have them.
Okay. One other question on the
Sure.
Net patient revenue for this fiscal year and for next fiscal year
Yes.
is going from basically 54 million to 61, so about 13 or 14%
Yep.
increase. But our patient activity is projected at 3%.
3 or 4%.
Where's
Well, part
the
of it is
disconnect
the
there?
imaging center and the new clinics. They are going to produce a pretty significant amount of dollars for the hospital. The other is in last year, we actually collected almost 57 million. So this year was kind of a retrograde. So I'm with Dr. Blackledge in leadership, we've been producing closer to $4.8 million a month since she arrived. So we are projecting, we're putting a load on there. We're harvesting better. I do think one thing that's not in here, I know I talked about the Cerner project or Oracle. I do think when we have a truly clinically driven revenue cycle, we are going to harvest more on the same work that we've done in the past. But I'm not projecting that in here. Most of this is the imaging center, the Metro Center, where you've got two physicians whose practices are senior focused. You know, the utilization profile that you want in terms of, you know, I love 40-year-old people, but they don't produce a lot of hospital utilization for us. So a senior focused center there at Metro is going to make a big difference for us in the coming year.
So it's new. It's like
Yeah.
I can see that we can expect hopefully more than 3% increase in outpatient.
It will
of
be
new-
because,
new
right,
clinics and-
same store 3%. The Metro Center Clinic itself, in the past year, before we took that center over, they were producing $3 million a year in collected revenues at their clinic. So that's baked in here.
Okay. Thank you.
Dr. Hudson, any questions?
He answered it. He covered it. Thank you.
Okay.
Excellent. I had one with regard to salary. You mentioned this, which is helpful to talk about the full year. But as I was looking at some of the just, I guess, not applicable to our current packet, but in the board packet, it talks about people we are hiring, people we are, I guess, relicensing, if you will, and then people we have had leave. Does the number with salary expense also add in the loss that we are also having with staff? And if so, does that offset some of the cost?
You're talking about turnover of staff?
Yeah, turnover of staff.
Yeah, it does because, I mean, I don't know how exactly in regular, like government, traditional government, you may have positions and vacancies and so forth. So I use real time. So the historic vacancies are already baked into the 59 million, if that was your question.
Okay.
Yeah. And certainly ask your questions. I just say, you know, we're going to be back to this board again, to the Finance Committee and board again, because I'm sure there will be changes to the budget, whether it's in the Metro process or ourselves when we get 2 months more of data to bring into this budget. So I hope it doesn't change significantly, but you're going to see some movement when we bring it back for final approval, probably end of May or maybe end of June when the new fiscal year from the city starts. So we'll get another crack at it.
How likely do you, are you comfortable with the 63 from the city?
I'm going to look at Dr. Webb because he probably has better sense than I do. There you go.
Okay. Anybody else? Okay. If there are no other discussion points, I would like to have a motion to approve the fiscal 25 budget assumptions. It's okay, you're on record, so it's fine. Just keep speaking into the microphone. He didn't turn it.
I was asking you to turn your mic on.
It's taken me a couple of years to get used to the way this goes because this is very preliminary in that you know, Bruce is being and the team are being asked to project a budget when they have only half of the current year, and correct me, but the way it works is this goes to the mayor's office, and he presents an alternative budget, which is different. And so I think it's well said that what we're approving here is sort of the assumptions. We're not actually approving a budget, which is going to be ultimately, what the budget is. Is that fair to say? Is that okay?
Can I just add, because I do think the legal director, Mr. Dietz, really stressed that this finance committee and board has to be comfortable with what we are bringing forward. It is a projection, and it is 18 months, we've got 5 months of real when we started putting this together, and then we closed December, so we can kind of see what that looks like. But yeah, this is going to be going out from July. It's 6 months from now, starting point. But this is consistent with what Metro does for all of their own agencies. So, but ours changes, I think, a little more dramatically than maybe the water department does or the parks department, just because we're trying to take care of patients. We're trying to build volumes in geographies that we've not been involved in. So it is a little bit more, I hate to say speculative, but it is a lot more projections in some of those new spaces. If it was just the same thing every year, this would be a lot easier to work with. I agree.
Well, and taking care of patients and running hospitals is the same thing every year because the cost increases.
It does. It does. Yeah.
And I can appreciate this year us having more input early on in this process, and I think that's the feedback we've given before, because historically it would go to the mayor's office, and then we're kind of backpedaling, trying to understand as a board how some of the decisions were made, et cetera. So it sounds very reasonable and practical to have this level of engagement from the board prior to it even reaching the mayor's office. So thank you, of course, for spearheading this and your leadership and thoroughness.
Thank you.
All right, being that there's no further discussion, do I have a motion to approve the fiscal year 25 budget assumptions?
So moved.
Second. Any question? All in favor?
Aye.
Aye. Motion passes. Next on the agenda is the financial reports.
All right, we've got November and December. So we're trying to catch up a little bit. So for the month of November, we had a little bit lighter volume than October, dropped from 222 to 203, below the budget by about 13%. And I would just say our observation admits were a bit above budget, but actual admissions were a little below. Our ER volumes were 7% below budget for that month of November. November is always sort of a slow month, most hospitals, just because of the holiday period, kids out of school and so forth, and we have similar. So our length of stay, that's been a focus for the hospital the last several months, and you probably notice our length of stay has been extremely low, which is a good indication of efficiency in moving patients through the system. 3.6 for the month. The budget was 3.9. Our case mix did drop a little bit. That's the acuity of the patients at discharge. So, we still struggle a little bit. ER volume produces almost 90% of our admissions. Dr. Webb, Veronica, and others were working on some refreshes to the emergency department and some of their process. We used to do as many as 3,000 visits a month, and if we were at 3,000, we would probably see a pretty significant increase in our admissions and fannies in the bed at the hospital. So that's something that we are working on. Surgery volume dropped in that last month from 33 to just 24 cases. Budget was 38. For the fiscal year to date, we're at about 148 cases, so we're down a little bit from last year. We did have a couple of surgeons that were out for pretty long periods of time this year versus last year, medical, and so that's had an impact. Cath lab volume has been really good this year for us, even though we're sort of online with where we were last year. Deliveries, which were really high last year, dropped to 26 this past November. Budget was 35. And so for the fiscal year to date that we're in, 24, our deliveries are actually down about 8% from last year. They were up 15% last year. So it's been up and down with our Meharry providers and deliveries at the hospital. Our clinic visits in November dropped from about 3,400 to a little over 3,000, under budget. We don't have any of the new clinics in here yet. Last year, our clinic volumes were a little over 40,000 visits for the total year. So patient revenues were probably a big driver for us in November. So 23.7 million was our gross revenue for the month, about 10% below the budgeted threshold. Most of that was patient days being lighter than expected. Collections, there was net revenues of 4.9 million were actually better than the budgeted amount. That was just good payer mix. We had a good collections month in November, and that allowed us to only to have a little better than 20% harvest rate. That's what produced a positive 147,000 benefit there. And then our other revenues, as you know, they've been high this year because of some of the federal monies that have come to the hospital. And so they were both well over budget, 280,000 and a 1.9 million above the budgeted number. So all in for the month of November, we had almost $13 million of net revenue, which was 2.4 million ahead of budget. And with our expenses, salaries were about 4.5% higher than budget, and contract labor down slightly this month, but still higher than our budget. Most of our other expenses fell in line. We were over budget, about 800,000 on costs. And so for the month, with that nice net revenue, we had an almost $620,000 positive operating margin. We were budgeted to lose 927,000. So for the year to date, through 5 months, the positive margin is 6.3 million positive. The budget was $4.4 million negative. So we're, way ahead of plan, thanks to a lot of other revenues that have helped us and good collections effort from our team. So we're well ahead of plan for the first 5 months of the year. Happy to answer any questions. And I don't know, do you guys want to do November by itself, or do you want to do them together?
Yes, I was going to say we can collectively.
Okay, all right, well then we'll move on to the December financials. Again, admissions a little bit stronger this month, December, 213 admissions. Patient days rose to 889. Our length of stay went up a little bit to 4.2, but still below the budget of 4.6. Our ER volume went up from about just shy of 2,200 to 2,354 this month. Admissions through the ER were a little bit above budget. Our clinic volume dropped off quite a bit in December. We had weather and we had holidays, of course, so we budget straight line on clinics. We don't try to do the dance between different month presentations. Inpatient surgery cases were basically flat with prior months, still running below budget, and outpatient cases similarly. Our cath lab was a little below budget. Deliveries dropped again in December to 20. There were 26 the prior month, and so a little bit of a decline there. And just like most things, if I told you that January numbers and February numbers were back up, that's what happens. I mean, it's just a sort of a fluke. That those numbers bounce all over for us. Case mix was pretty low for the month at 1.27, which was a little unusual, but in terms of total revenues for the month, 22.9 was the gross revenue, again 13% below the budget. Our collection, it was a less favorable month for collections and payer mix, so we only harvested 4 million compared to a budget of 5.2, so a significant negative variance there. The other revenues that sort of helped us last month did not this month. We did collect, we had $2.5 million in other revenues, but the budget was actually 3, so we had a slight negative there as well. So for net revenue for the month of December, 11.4, budget was 13.1, so we're in a hole about $1.7 million for the month of December. Expenses, we did bring on some of those physicians in clinic in that month, and so our salaries were up in December, about 10% above the budgeted number. Contract labor was pretty static, so, you know, hopefully we're going to make some headway there and start to bring those numbers down. And when we get less contract labor, of course, you're going to see a little bit more salaries because we're going to replace those people with salaried staff. The rest of our expenses were pretty well in line. We were about $700,000 over for the month. Most of that was in contract labor and salary, almost entirely there. And so for the month of December, a poor month, we lost $1.1 million. The budget was to make money with that other revenues. So we had a negative $2.4 million miss. Still, if you cross over to the full 6-month period, we're at a $5.1 million positive operating margin. The budget was that we would have lost $3.1 million for the first 6 months. So we're still solidly ahead of plan. January has looked pretty good. And so I think we're going to continue to show positive on a go-forward basis. But that's a quick, dirty November, December.
I have a question for you.
Yes,
I know we've been anxiously waiting for the capital funds from Metro, and I see here still no access to that. Do you have some type of kind of tangible
well,
update?
the good news, and I know Dr. Webb and Dr. Brown and others know that yesterday, in our conversation with Metro, we were given the green light to start sending through our capital. We've spent almost $4 million just in the first 8 months of this year. And so yesterday we sent the first $1.4 million of capital to Metro. And now it's just, they make us put them, each one on a particular form. You have to follow a very specific process. And we'll see how quickly they turn around. In the past, it's been pretty quick. So I'm hoping in the next 2 to 3 weeks, we'll see some of that come back. I've got another 1.5 million that we've readied to send to them early next week. They're well aware. And they've worked with us well in that regard in the past. So we finally broke through the jam there. Now, we need more capital than the 7.3, but we're happy to finally have access to it. It's going to allow us to not only get reimbursed for stuff we've spent, but catch up with some of the vendors that have been partnering with us, let's say.
That's awesome.
Yeah,
Thank you.
Good question. Had you heard something in the wind?
No.
Okay.
Curiosity.
All right. Yeah, they were both happy when I told them yesterday that we were finally able to send some of those out. Yeah, thank you.
Okay, great. No other discussion. I'll entertain a motion to approve the November 2023 and December 2023 financial reports.
So moved.
Is there a second? Any question? All in favor? Aye. Motion passes. Next item on the agenda is the revenue cycle report.
Madam Chair?
Yes.
We were going to defer those. I think we're going to
Okay.
produce those at a later date. They're information only, but Dr. Blackledge has been a little busy. She did have one really good month and one not as good month, but she did pretty well. She'll have that. We'll catch you up on the next one. Doc.
That's fine. That's fine. We know where you live. We'll come back to you. Okay. Next item on the agenda then is the contracts to approve. And the first one on the agenda is the community health marketing. So, sorry.
And this is essentially the same packet. The only thing changed was the contract start date and the decrease of 17 months for the full term to 16 months. Good afternoon, everyone. What I handed out was just essentially a revised analysis that the only changes were the contract start date from February 1 to March 1, which also decreased the total amount of the contract from 17 months to 16 months. So just to recap from the last board meeting, we did the RFP process in October. 15 agencies were emailed a copy of the RFP with a request to respond. Of the 15 agencies, 4 responded with an intent to submit. We did have some outside agencies who also responded, just they were cold calling. So if I received an email during the RFP time, I just sent them the RFP and said, please see we're in the middle of an RFP process. And we finally ended up with 3 proposals by the deadline date, 2 local companies and 1 from New York. We set up 2 teams to review the RFP. One consisted of myself, Susanna Sells, our contract manager, and Tom Cooper, who's our director of procurement. So we did the initial scoring just to make sure that all areas within the proposals met the RFP requirements. We then had a second group come in who consisted of directors and leaders within our external areas of the hospital, from Nashville General Hospital, Nashville Healthcare Center, Nashville Healthcare Diagnostic Imaging, the School of Health Sciences, as well as a few executive leaders, sit in and score the actual presentations. Because we only had 3 and their initial scoring was well within, I think, 10 points of one another, it made sense to have all 3 do the presentation to this committee. After scoring that committee, the original group of myself, Susanna, and Tom then opened up the fee schedule proposals. Once reviewing the fee schedule proposals, we selected one of the companies, and truly based on value. Any one of these 3 companies could come in here and do an excellent job, but based on my budget, based what we are looking at here at Nashville General, from a community and grassroots effort, the selection was community health marketing. After the board meeting, it was deferred to this meeting where board members would be able to come back and ask further questions. So I did have some great dialogue with Mr. Lesser. He came and met with myself and Dr. Blackledge, and then Chair of Finance Christy Smith came yesterday and we had a conversation as well.
The board asked for the RFP and for information for all the bids, and you provided. Thank you very much.
You're welcome.
I did not come in. I'm on. I would defer to Ms. Smith's comments since she came in and went over things with you in detail.
Sure, and if it pleases the committee, I'd also be happy to have Mr. Lester speak as well. I appreciate, I guess to start out, I appreciate your time. You got the information to us. We were able to review. You made yourself completely available, and that is, it's a lot, so I appreciate that. My interest specifically is that I am newer, and guess what? I'm chair of the finance committee, so I think you need to make sure that I'm asking the questions, and more importantly for me, as I mentioned to Kathy, is understanding the process, right? So this is the first kind of real deep dive for me being in this position, and so my goal is, I'm sure everyone who sits around this table, and everybody in this room, is to do everything that we can to try to use our time, talents, and energy to make this a great place, even better, and continuing to elevate the experience for everyone. And I think if we start with that fundamental basis at hand, I think that unites us rather than divides us. And I think it's really important that the staff, the team in the marketing area hear that and understand it is not about a criticizing opportunity. It's about a learning, educational, and elevating opportunity. And so I just want to be very clear about that. So I had read the comments. So there's about 14 different pieces of material. And they're pretty lengthy, and I had read comments. I looked at the RFPs, I looked at the individual responses, and then I read all the responses and grading for each one of the entities. And I do find some concerns, obviously, with each group, and I'll speak specifically to the current proposed winner of the RFP, mainly around quite frankly, some reputational issues. There is some concerns that were bubbled, and this is in the draft, so I'm not speaking out of school here. The issues with not having some data or in a limited amount of time frame, and then some questions about the actual client base and confirmation of the client base. So, again, you can probably pick apart most of them. I told Kathy the main issue for me was that we had 73% of the people that we reached out to didn't propose. And I asked why. The concern for me is why, right? Why wouldn't people want to work with us? Or why? Is it too small of a project? Is there a conflict of interest? Like, to me, that's the real question at this point. And going forward, I did read the contract as well to see that, there is a monthly required product back to us to be able to grade the effectiveness of the contracts. Of the materials coming back and the effectiveness of what's going on. And then also a 30-day out clause. So those are my general comments about it. But again, I guess start where I finished, which is a big thank you for your patience, both to the board, the staff, to really let me personally kick the tires on this and to feel comfortable with the process and understanding in this new position how that works. So, Mr. Lesser, do you have some comments?
Yeah, thank you, Madam Chair. I would agree with your comments as it relates to the staff and the process, and really appreciate the opportunity to spend that time with you and others to discuss how this happened and what the results are. I agree with the chair about the number of responses, and I wish there had been more, and maybe in the future we will get more. I also think this is really critical for us, because if we make the assumption, which I make, that the work being done here at the hospital is being done very well and needs to continue, that doesn't help us if the communication of that to our important audiences is not substantial and successful. And that's why I think I spent so much time on this, because this is a critical part of achieving all of the goals we want, primarily financial, but also making sure that the population that we serve, the citizens of Davidson County, understand what we do, respect what we do here, and want to be a part of this effort moving forward. And so I will support this contract with some of the same concerns that the chair raised. I think it's particularly important for us to keep a close watch every month and get that report. Kathy, whether it's from you and or from the organization themselves, I think that would be very helpful to have them here every month to present the month's work.
Definitely.
And what next month is going to be about and 6 months is going to be about, so that we can have a full understanding and most importantly, from my vantage point, how we can assist and be supportive of the effort moving forward. So thank you, Kathy. Thank you for the process, and thank you, Madam Chair.
Just to add on to that, I do appreciate both of you taking the time out of your busy schedules to come here and learn more. I mean, you don't know what you don't know, and I think we tend to sometimes be in a bubble, and it always helps to have board members come in, community leaders to come in. So anytime you can bring a community leader when you hear something going on outside, it just makes us better as well, because we're kind of blind sometimes. And so I appreciate having the opportunity to present a marketing report to the board every month.
One other question. This contract is for less than a year and a half. What happens, a year from now when it's about to expire?
Within the contract, there is an option to extend it for another year, just depending on the review, that they've hit all their marks, and where we are within the next year, we will evaluate.
Okay, so we'll, in addition to a month-to-month report, will we have a formal review?
Yes,
About this time next year?
we definitely can.
Okay, great. Move approval.
Is there a second? Any discussion? All in favor? Aye. Motion passes.
Thank
For
you.
your time. Next contract up for approval is CMS Imaging. Dr. Brown.
Madam Chair, that contract is a annual service agreement. It's a point of service contract. And what that means for us is that it's sort of at a discounted rate if you buy it when you purchase the machine. That contract will go into effect 2 years after we take possession of the CT scanner. Normally, those contracts run anywhere from $80,000 to $110,000 if you buy it after the 2 years the machine has been in. And then you'll see on there it has it talks about rotation. That's about 1,500 exams. And then after that, you have to start providing tube coverage. So that's why we went ahead and wanted to present this one to the board for consideration. And I'm happy to answer any questions.
So what this is covering, the per rotation fee, basically, or
any service that's needed and tube rotation, correct. Okay. Because normally what you would have to do in the past was you would have to buy what we call glassware, which covers your tube when it goes out. Yeah. And that's probably, the tube itself costs, I guess, about $90,000 to $120,000 just for the tube. And then you have the installation costs and all that goes with it. Or you can wait until 2 years after this warranty, the service warranty expires that comes with the machine, the manufacturer's warranty. And then that's normally, and that was 10 years ago when I was operating in the imaging department, was around $80,000 to $110,000 a year for a service contract.
So for the new scanner, the outpatient scanner,
yes, sir.
About to start, we've got 2 years.
Yes,
before we.
Yes,
Okay.
Manufacturer's warranty.
I had one quick question. After reading the contract, I didn't realize, I didn't see that there was any kind of out clause. It says that full payment is immediately due without discount, a deduction, or set off, et cetera. So if there's any problems with the contract or any problems with service, I just was curious as to your take on that.
Yes, normally what happens is there's a guarantee uptime in that contract that you read. Normally it's like 90 to 95% of the time uptime, and it gives a timeline in which the contract has to be, the maintenance has to be completed. And, 42 years of this, I've never seen anyone not meet that. Normally, there's a service rep that's local, which I know this company has one that's local that comes in within a certain amount of time. Like we have a 2-hour guarantee response time, and then there's an 8-hour uptime that they come in and provide a technician to come in and repair the machine. And what thing that this does, it allows that if they find that we need to replace the tube, once they come in and discover that, they place the tube on order, and within 24 hours, it's within the department and install. So that's part of the deal with the guarantee or the point of service contracts.
All right. Any
Move
further
approval.
discussion? We've had move for approval. Do I hear second? Second, okay. Any question? All right, all in favor?
Aye.
Aye, motion passes. Thank you. Moving on to prom pathology, Dr. Brown.
Again, okay, so this is a pathology. We're actually bringing on a pathologist. The pathologist that we were bringing on was employed by Meharry, but started seeking employment somewhere else. Currently, our pathology department is managed by, they have another pathologist with Meharry, but they work 2-3 days. That was the dean that moved back from not being the dean to a pathologist. We have another pathologist who chairs over at Meharry, but it really doesn't work in our pathology department. And then we have another pathologist that is very limited in what they can provide for us here at the hospital. So we know that to get the services that we want and to provide the level of clinical knowledge to our providers that order laboratory events, we need to move forward and make sure that our pathology department is secure, or we have the right person leading that group. And while he was with the Meharry before he moved over to us, he is our medical director.
So this is the same pathologist that we've had.
Yes, yes, this is the same provider that we had that was leaving the college because he was expected to be the medical director and teach on the platform.
And has Meharry been given the opportunity to provide a pathologist?
Yes, they had promised the current medical director an addition to the department, but that never materialized, and that's why he was seeking employment outside of our environment.
So he was expecting them to hire an additional pathologist.
Correct.
And they were unable to do that.
Yes, sir.
And this base compensation, is this for professional fees only?
Say that again, Dr.
Is it
Martin.
for professional fees only? Or is it, is it other expenses with the laboratory?
Well, it's going to be a professional, and we'll get facility fees for this provider.
And so, okay, so we bill for our pathology services, and we collect and keep
Yes, sir.
that revenue.
Yes, sir.
And we're basically paying him a salary.
Correct.
But the medical director fee is in addition to the salary?
Yes, sir. And the lab, and Mr. Pence is sitting behind you, who's our laboratory director. Raise your hand up, Rick. We have to have a medical director that has certain credentials in order for the lab to stay open. And so in order for us to bring on that candidate, we have to continue with the medical director because of the blood bank and the other areas of the lab that require a licensed provider that has a certain license in order to operate. And Rick can speak more to that. Come up here, Rick. Come up here, Rick.
You're on TV.
For State of Tennessee Medical Laboratory Board, Joint Commission, the AABB, which is American Association of Blood Banks, and also CLIA. He's our CLIA medical director, and so they have to have that accreditation for us to perform those services. And Dr. James is accredited, and he's qualified for all those, for all the regulatory agencies.
Can you confirm that these compensation amounts are for the term of the agreement, or is this annual? I just want some confirmation on that.
That would be annual
Okay.
compensation.
That's what I thought. Thank you.
Can I just, one little clarification, just so there's no confusion. We bill for the technical today. Meharry does bill for the professional because it's their providers that are providing the interpretations for the lab. In this scenario, we would also be billing for the professional because this contracted entity would work for the hospital. The other is, in the state of Tennessee, hospitals are not allowed to employ pathologists. So the only way we can get those services is through a contract. Just FYI, just so we're not confused.
Yeah.
He can't be an employee of ours technically.
And Meharry has 2 additional pathologists
Yes,
in
they
their
have.
employ, but
Yes.
they're not, they're only teaching?
They're doing predominantly teaching, yes.
Okay. It's just still a little unclear to me why. Did he basically resign from Meharry?
Yes.
And we're hiring him?
Yes, sir.
What is the expected, we understand the expense, but what's expected revenue?
The expected revenue for
Yeah,
that?
that would come in, that would support a $460,000 annual income.
Well, one of the things would be expected if Dr. James left, we'd probably have to close our lab down. That would be the first thing that we would have to look at. Who would we have in order to operate the lab that had the credentials to do that? The other thing would be with Dr. James being on board full time, he would meet all the requirements that we needed in order to facilitate making sure that what we're doing in the lab is correct. Currently, Mr. Pence is driving that work because when Dr. James was here, he was only here 10 days out the month.
Is this salary,
It's based on MGMA, Dr. Martin.
and is it basically the same expense as we were paying
No.
when he was at Meharry?
No. We were paying partial payment to Meharry for their provider. So we were paying half an FTE.
So we had half an FTE pathologist before, now we're going to have
A full.
full-time.
Yes, sir.
And you mentioned previously he was giving like 10 days of.
10 days of his time when he was employed through Meharry. Now we get a full-time FTE here at the hospital.
Okay. Thank you.
I guess the bottom line is Dr. James was going to leave the system. Is what precipitated the kickoff of this whole negotiation was he was going to leave the system, and if he left the system, then we wouldn't have a medical director here at the hospital.
Understood. And it looks like you also have some 14 days of call coverage as well, so I'm sure that's nice. Okay, any other comments? If not, we will move to approve the Prime Pathology PLC contract. Do I hear a motion to approve?
So moved.
Okay, is there a second?
Second.
Discussion? All in favor? Aye. Motion passes. Thank you. On that note, I think we're finished, so I'll move for adjournment.
I would like to